Good morning, everybody. And seeing all of you on Sunday morning, it's really heartening that how keen is our people to learn and improve their patient outcome. So I'll be talking on a very, very interesting subject, which is high bleeding risk. Many times we have done PCI, and subsequently we have found that the patient has developed a GI bleed or a intracranial hemorrhage, and we get worried. So the whole PCI, the major tumbling block for all the PCI was stent thrombosis. We used to put a metal, and subsequently we used to find that there is a big clot. So to avoid it and prevent it, we started using multiple agents, starting from aspirin, and then subsequently we started using warfarin also, and then the era came where we started using dual antiplatelet, and we found that a dual antiplatelet with an aspirin and a thienopyridine gave a better result compared to aspirin and warfarin, and that is where the whole concept of dual antiplatelet therapy started gaining traction, and we still are using a dual antiplatelet as a default strategy. But over a period we found that as our experience with angioplasty improved, we started doing more and more complex cases and more sick patient with other comorbidities, and that is where the downside of dual antiplatelet, that is bleeding, started coming into picture. And that is where we started worrying that how best we can manage a patient who has a high bleeding risk, and then so that we can give him the best of angioplasty and at the same time control our bleeding risk in this patient. So what exactly do we mean by a high bleeding risk or an HBR? The multiple definitions were given, but the most standard definition which we have been using nowadays is, if a patient has a BARC 3 or 5 bleeding, if a patient has a BARC 3 or 5 bleeding risk, which is more than 4% at 1 year, or the risk of developing a ICH is more than equal to 1% at 1 year, then this patient is considered a high bleeding risk patient. So what exactly is a BARC? They have classified the bleeding into 5 categories, 1 to 5. Type 1 is very, very minor bleeding which doesn't require major treatment, it automatically settles down. Type 2 is clinically overt bleeding which requires treatment but does not fit the categories which are mentioned below, that is type 3, 4, 5. Type 3 has 3 categories. 3A, where you need 3 to 5 milligram drop and you need a transfusion. 3B is more than 5 gram hemoglobin drop and it requires a surgery or a vasopressor to maintain the patient. Type 3C is patient has a intracranial hemorrhage or a intraocular bleed. Type 4 is bleeding related to CABG, where the patient needs more than 5 unit blood transfusion in 48 hours, or if the chest drain, it gives more than 2 liter of chest tube. Type 5 is fatal bleeding. Patient has died and you have done an autopsy and you find that definitely the death is because of the bleeding in this gentleman. So out of all these things, the most dangerous are 3 to 5. So that is what we consider as a high bleeding risk patient. So these are the risk factors: age, renal disease, liver disease, active cancer, anemia, low platelet, planned dual antiplatelet with trauma, oral anticoagulant, planned bleeding, and ICH or AV malformations. All these are risk factors which leads the patient to develop all this. So what exactly is the incidence of bleeding when we do PCI? In a general population, when we do PCI, the incidence varies from 2.5 to 6% in various trials. So how do we predict? The most important is, how do we predict that this patient is going to have high bleeding? So various scores were proposed. The REACH score, DUS score, almost 6 scores were there. But currently the most standard is the BARC criteria for HBR, where they have classified the patient into 2 categories, major and minor. And if the patient has 1 major or 2 minor criteria, he is considered as a high bleeding rate. And out of all this, I'll enumerate 1 criteria which many times we ignore, that is hemoglobin less than 11 gram per deciliter is a high bleeding risk major criteria. So anybody who has anemia less than 11, he is to be considered as a high bleeding risk. If his hemoglobin is 11 to 13 in male or 11 to 12 in female, it is a minor criteria. So many times we see patients coming with a hemoglobin 9, 8 or 10 also. We just don't bother about it, but mind it, this patient is in a HBR category. Other criteria is always there. Age more than 75 years, it is actually a minor criteria. If the patient is on OAC or if the patient is having renal failure, many times we think renal failure is high ischemic risk, but mind it, if the eGFR is less than 30, it is considered as a high bleeding risk, but also it also adds to high ischemic risk also. Similarly, if a patient platelet count is less, less than 100,000, it considered as a high bleeding risk criteria. So cirrhosis, bleeding diathesis, any malignancy, normal within 12 months, previous spontaneous ICH, post-traumatic ICH within 12 months, all these are considered or a recent major surgery or a major trauma within 30 days before PCI is also a high bleeding risk major criteria. So keep these in your mind and then decide what will be your strategy when you are going for an angioplasty in this patient. In India, we don't have much data. There was a master DAPT score. Based on that, the Thermo company came up and they said that 20% of Indian PCI are also high bleeding risk. So what happens if we do PCI in a high bleeding risk? There are two things. When you do a PCI, what is the problem? And if the patient after PCI develops a bleeding, then what happens? If we have already done a PCI in a high bleeding risk without bothering about what to do, then we are subjecting this patient to a very high risk of mortality at 4 years, which is 15.7% compared to 3.8 with a low bleeding risk. And if a patient has already developed a bleeding after PCI, then the chance of annual mortality rate is almost 21.5 per 100% years. So this is the problem. So we must think about it before we put our stent in this subset of patient. So basically it's a balance between ischemic risk and a bleeding risk. So how do we adjust that blood? We know that thienopyridines are definitely of benefit, but the problem with thienopyridine is the bleeding risk which comes with it. So what is the downside of dual antiplatelet? You can see here, patient was given DAPT. Many times we give them DAPT for 3 years, 4 years. The moment you have given for more than 12 months, because the standard recommendation right now is dual antiplatelet for 12 months only. And the moment you go beyond that, the bleeding risk has gone up to 2.5% compared to 1.6% in a single antiplatelet. So be very careful when you extend your DAPT after 1 year. 2-year mortality according to the bleeding. If the patient has developed a post-discharge bleeding with transfusion, the mortality, if the patient has developed bleeding, the mortality is almost 5.03 compared to post-discharge MI. So if a patient has an ischemic event after a PCI, then the mortality is relatively less compared to a bleeding episode if he develops after doing a PCI.